therefore triple therapy is considered. Arguably, the most effective one is the PAC 500. That is PPI plus 1 gram BD amoxicillin plus 500 BD clarithromycin. Very easy to comply with, and therefore very, very effective. We looked at alternatives like the sequential regimen. So we have alternative first-line regimen as the sequential therapy. If this fails, then you can do the quadruple therapy or the levofloxacin one. And then the third-line agent, at that point, you will have to do culture and sensitivity. Probably there is the presence of resistance. In that case, agents like rifabutin could even be considered. I think that is where we got to. Any issues, any queries, any additions so before we continue?
Yes, please. I want to ask that. Why wouldn't we just do the culture and sensitivity first before treating? Instead
so
of
you see, when you are doing treatment, all these labs would not normally, it comes with cost. So if there is enough evidence that suggests that doing a certain treatment straight away without even doing labs also works, and there is enormous evidence to back that, why won't you go ahead and do that, but spend money to do the labs? Remember, the patient will have to pay. But if you have a very strong evidence that's backing your claim, and that when you do it, it's effective. Then there is no as in rationale in going to spend money to do the culture. In any case, of culture and sensitivity. That is the norm. So in this case, you have very strong evidence to back the treatment without even doing it. So in rare cases where there is resistance, then that is when you consider spending cash and time and other resources to do the labs. Effectiveness is what we are talking about. So if you do it straight away, it's been found to be cost effective. Low cost, the treatment is effective as well. That is why they are saying do this first line. Even if first line doesn't work, go ahead and do second line. It's just like when you are treating conditions like HIV. Somebody may bring resistant forms, but it is known that what we are talking about. You can do the first line. If you do it straight away, first line, if it doesn't work, found to be cost you can even do second line. Low cost, the treatment is effective as well. That is why they are saying do this first line. Even if first line doesn't work, just go ahead and do second line. You consider just like the next when you are treating conditions. So in most like cases, HIV, you have enough somebody evidence may bring that, and you are free to resistance forms. So that is why it is known that what we are talking about. You can do the first line. If you do it straight do first line, if it doesn't work, found to be cost you can even do second line. Low cost bacteria. The treatment is effective as well. Strategy. That is why they are saying do this without first line. Even if first line doesn't work, just go ahead and do second line. You consider just like the next when you are treating conditions. So in most cases, no problem. You have enough somebody has bring on some few resistance forms. So that is why it is known that yes, you can do the first line. You do it straight the first line. It doesn't work. You can even do second line. Low cost, the treatment is effective as well. That is why they are saying do this without line. Even if first line doesn't work, just go ahead and do second line. You consider just like the next when you are treating conditions. So in most cases, no problem. You have enough somebody has bring on some few resistance forms. So that is why it is known that yes, you can do the first line. You do it straight the first line. It doesn't work. You can even do second. So I'm sure maybe somebody has this strategy. That is why I don't have any other advice. Even if the first line doesn't work, just go ahead and do second line. You consider just like the next one. In most cases, no problem. You have enough somebody has bring on some few resistance forms. So that is why it is known that yes, you can do the first line. You do it straight the first line. It doesn't work. You can even do second. So you still hear that? So I'm sure maybe somebody has this strategy. That is why
I think it's only him.
All right. Okay. So we got to this slide. So this, apart from the popularly known ones. Recently, there have been other recommendations from some few trials that locally you see one or two prescriptions going by some of this regimen. So, for example, the so-called hybrid regimen. These ones are not popular in the United States and Canada, North America, but Europe and nowadays over here, if we do the triple therapy, the normal one, and it doesn't work, you normally see some few doctors going by these strategies. So, for example, the hybrid strategy is to use a standard dose PPI. So, for example, omeprazole, 20 milligram BD. Hello? Hello? Is there a problem, please? Please, can you hear me?
Yes, please.
All right. So the hybrid regimen goes with a standard dose PPI, meaning if you are going by omeprazole, then you are doing the usual 20 milligram BD. Then you add amoxicillin 1 gram BD plus clarithromycin plus metronidazole or tenidazole all together for 7 days and 7 days. So if you do your first, almost like the sequential therapy. So the first 7 days, you do PPI, standard dose, and then you add your 1,000 milligram amoxicillin BD for 7 days. Then you do another 7 days, this time combining a standard dose PPI with amoxicillin again at 1 gram BD. You add clarithromycin, 500 BD, and you add metro or tenidazole. So double therapy for 7 days, quadruple therapy for another 7 days, a total of 14-day therapy. Obviously, this will not be first line. That is when you try first line, it doesn't work. You can also do levofloxacin triple therapy. So it means that the regimen will by all means contains levofloxacin. Here again, PPI at standard dose, levo 1 daily, then you add amoxicillin 1 gram BD for straight 10 to 14 days. That is the levofloxacin triple. Then we have the levofloxacin sequential. So in sequence, similar to the hybrid one, that one too is in sequence because you do some first regimen by certain course, then you continue with another course. So levo sequential is standard dose PPI, amoxicillin 1 gram BD. You take this for 5 to 7 days. Then you continue on for the next 5 to 7 days, combining a PPI standard dose with amox 1 gram BD, levofloxacin feature because the name comes with levofloxacin. So you can't miss out on that. So plus levofloxacin 500 daily. Then you add your metro and tenidazole. Then the load. So PPI standard dose again with levofloxacin half strength, which is 250 milligram daily. You add your metronidazole or tenidazole plus doxycycline. Here again, it's advisable that you do at least 14 days, 10 to 14. So these are all options that if first line regimen fails, the popular ones that we all know, a PPI plus 2 antibiotics from Amox, Metru, and clarithromycin. In case that one fails, you can use any of this regimen, be it the hybrid, levo sequential, levo triple, or the load regimen. And then you see, in case it doesn't work, then you can do your culture and sensitivity, then you continue. So these are all options that you can recommend, but don't do it as first line. You do it when maybe first line doesn't work, then you recommend this to your clinicians. So we've been able to do NSAID induce. We've done H. pylori induce, where we include antibiotics. Ulcer, stress ulcers. So let's look at how we'll be able to prevent stress ulcers. Normally, in critical illness, patients do suffer from stress ulcers. So let's try and then look at that. I hope there are no issues. Can we continue? So, as I said, stress ulcers are very common in critical illness. Normally, you realize that almost about a third or almost 100% of critically ill patients, 1 or 2 days after their admission at the ICU, will present with stress-induced ulcers. It's very, very common thing that we normally find. And unfortunately, about 2 to 5% out of these patients will bleed from the ulcers. So almost all of them, or 75%, after a day or two on ICU care, may develop stress ulcers if not properly managed. And out of this, 2 to 5% may bleed from the stress ulcers. Now, coagulopathies, issues like DIC, where you have all parameters pointing towards the possibility of bleeding very high. So at that point, if you are suffering from any ulcers, it predisposes the patient to the presence of bleeding. Very, very dangerous. Critical illness and ulcers are common. And when during that time the patient's coagulation parameters are poor, it increases the patient's chances of bleeding. And therefore, stress-induced ulcers are prone to bleeding. Now, let's look at the pathophysiology. So the issues surrounding critical illness normally would lead to all these possible issues. For example, a person may have mucosal damage, that is the GI mucosal damage, due to greatly reduced supply of blood to the GIT. In most cases, blood is focused on vital organs during critical illness. So vital organs like the brain, the heart, the kidneys, the liver, affecting other areas of the body. In critical illness, there may be issues like hypovolemia. As you have hypovolemia, it affects your blood volume and therefore blood supply to areas that are not of priority. Then you may also have issues like reduced cardiac output, again, perfusion issues. So both hypovolemia and reduced cardiac output will give us perfusion issues. In critical illness, patients may have inflammatory response. Some of these are vasoconstrictors in nature. Stressful conditions lead to the release of stress hormones, including catecholamines, vasoconstriction, reducing blood supply to the GIT. With all this, in case you have the slightest injury, then it's going to affect wound healing, because you need blood supply to give you oxygen and nutrients that are needed for all these parameters: hypovolemia, catecholamines, hormones that we release. This will also decrease prostaglandin synthesis. Yes. So apart from the catecholamines, adrenaline and co, that will cause vasoconstriction. Cortisol.
Please, hello.
Yeah, hello.
Please, your line is breaking. Can you repeat
Hello.
what you said about the inflammatory mediators?
Hello.
Yeah, your line is breaking.
So inflammatory mediators, some will cause injury You have this tumor necrosis factor and the others. They can cause injury. Others causing vasodilatation will reduce mean arterial pressure and therefore reduce perfusion. You have catecholamines being released during stressful conditions, vasoconstriction. You have cortisol being released as part of the stress hormones, reduce prostaglandin synthesis. And we know the importance of prostaglandins as part of the defense mechanisms. If you don't have prostaglandins enough, you are going to have reduced gastric bicarbonate and mucosa secretions. These are very, very important as part of the defense mechanisms. If you have mucus enough covering the surface of the gastric and the GIT lumen, what happens is that it prevents direct contact of electrolytes with the epithelial cells and therefore diffusion into the tissues is reduced. So if you have acid, for example, because of the barrier, it doesn't diffuse back into the tissues to cause damage. Now that you have reduced prostaglandin synthesis from cortisol release, you are going to have reduced mucus production, high possibility of electrolytes like your H plus having direct contact and therefore diffusing into deeper layers, causing injury. So all these are possibilities in critical illness. That is why critical illness is a very strong issue in relation to stress-related mucosal damage. I repeat, in critical illness, hypovolemia, reduced cardiac output, and others will compromise perfusion. Again, blood supply is concentrated in this situation to vital organs, affecting organs that are not considered top priority. Inflammatory mediators release can cause injury. During stress, you release catecholamines, you release cortisol. Catecholamines will further cause vasoconstriction, further minimizing blood supply to the GIT. Cortisol will help reduce prostaglandin synthesis. It minimizes the metabolism of arachidonic acid, and therefore the end product, prostaglandins, reduce. Once you don't have enough benefits discussed earlier, we are not going to enjoy. Reduce bicarbonate, reduce mucus, even blood supply, because it has vasodilatation effect. We are not going to get it. And therefore, it's not going to help in wound healing, if any. All these will predispose the individual to injury. Bad thing is that during this illness, the patient would normally present with coagulopathies. Coagulopathies with injuries, the patient is likely to bleed. And therefore, ulcers that bleed are very common in critical illness. Critical illness is a very strong factor when you are talking about ulcers, that is GIT ulcers, either duodenal or gastric ulcers. Any queries? Any queries? Any queries? All right. So in critical illness, due to the condition itself, and then the strategies that are used to manage the patient, almost all of them are stressful in nature. Almost all of them are stressful in nature. And as the name suggests, stress-related mucosal damage. If the condition is causing stress and its management is also causing stress, then of course the patient is in trouble. So considering situations where the patient has respiratory compromise, and therefore the patient needs a ventilator support, pushing this tube through somebody's airways, it's not easy. It is not easy. It's very, very stressful for the patient to be comfortable with such a procedure. And therefore, patients put on mechanical ventilation for up to 2 days or more, it serves as a high risk factor for stress-induced ulcer. As I said, critical illness comes with coagulopathies, for example, GIC, and therefore that can even contribute to bleeding. Patients with renal failure, these are all stressful conditions. Old age, of course, already your mechanisms, your defense mechanisms are compromised, and you are presenting with additional stress-related factors. You are in trouble. This has also been found to be very common with male sex as compared to their female counterparts. Epidemiological studies, you study or you do your research work, you try to compare the incidence of a certain phenomenon in a certain group of individuals. Then with enough evidence, you realize that if you have, let's say, 100 trials, almost 90 or 80 are all telling you that mostly it happens in males, then probably there is something there that we need to investigate. Why is it common with males more than females? Is it that males do have special risk factors that predisposes them to the condition or not? Could it be anything like a compromised defense mechanisms with males as compared to females, eating habits, social issues? Males do smoke more than females, alcohols, whatever, we don't eat well. All these could explain why male sex is a risk factor to stress-related problems. If you have acute respiratory failure, that is stressful. If you are in shock, you are having hypoperfusion, stressful again, especially when it comes with issues like septic shock. That is inflammatory in nature, very, very stressful. Myocardial infarctions, all these are stressful conditions. And as expected, you will not be surprised if you see the patient suffering from stress-related ulcers. So these are all possible risk factors that can predispose individuals, and they are all common critical illness situations. And once you have them, you are in big trouble. These are all additional stressful conditions: spinal cord injuries, traumas, burns, what have you. These are all there. The good thing is that for stress-related injuries that occurs or that happens in critical illness, the moment the patient is able to take food orally, it reduces the risk. The moment the patient is able to take food. So, for example, maybe right after surgery, you are admitted, they are saying that maybe your condition, they performed laparotomy, and therefore for the next day or 2 days, you are not supposed to take anything per oral until we see some bowel sounds, bowel movement. Then at that point, you are at risk. By the moment you eat, you realize that at least you have some material in the GIT, the acid that is being produced, the pepsin that is coming in, at least that food may form a barrier between those harmful agents and the GI lining. And therefore, it is proven that patients who start or restart oral feeding, it protects them from stress-related ulcers. So normally in the ICU, before you restart enteral feeding, you are normally put on PPI regimen as a form of cytoprotection. But the moment the patient resumes enteral feeding, the PPI, that is the cytoprotection, is withdrawn. It's no more necessary. Why? Because the enteral feeding can do the job. And if we can do the job naturally, why do we have to employ drugs? So the possibility of early enteral feeding is a key factor to protect patients. But of course, if there are contraindications to enteral feeding, you can't start. It's only when there is a clear indication that the patient can tolerate enteral feeding, then we start. Or we start, and once we start, it's able to protect the patient. All right, any queries? Any queries? All right. So then how do we prevent? What are the strategies available to protect patients in stressful conditions like critical illness from developing stress-related ulcers? The options include antacids. So we are utilizing the defense mechanisms to try and protect. Why? Because in critical illness, all these defense mechanisms are compromised. Bicarbonate production is compromised, and therefore we can use an agent to mimic the action of the bicarbonate that is produced by the GIT. And therefore, antacids are the best agent to be used, just like the way bicarbonate will act. So they are employed to neutralize the excessive acid that is produced. However, the effect of antacids are short-lived, and therefore one may have to do repeated administrations. That is a limitation when you are considering antacids. Of course, there are several other metal that you have in there. If you have aluminum containing products, it may rebound acid secretion. Magnesium containing may give you a problem of diarrhea. So all these are there. Now, to avoid diarrhea or constipation, you will see so many products nowadays on the market combining both aluminum salt and magnesium salt in one product. This is to make sure that the aluminum's effect of constipation will be cancelled by diarrhea that will be caused by magnesium. So when you combine these two in one product, your patient will not suffer from either constipation or diarrhea. You are cancelling out. So some kind of pharmacokinetic interactions, we are taking advantage. One ingredient will cause constipation. One ingredient will cause diarrhea. Let's combine them so that we come to a neutral point. No diarrhea, no constipation. Now, some individuals may not be able to tolerate excessive sodium, especially patients with congested problems. And most of these antacids will come with high levels of sodium content. And therefore, in patients like heart failure patients, kidney patients, you make sure that you give them antacids with low sodium content to avoid giving them excessive sodium. How do you define an antacid with low sodium content? Can somebody help us? When do we say that certain antacids are low sodium content antacids? Considering either per tablet or per certain meal, if it's a liquid preparation, you normally say that, oh, this antacid is a low sodium content antacid. Vice Captain, can you help us? How do you define a low sodium content antacid? Because this is very, very important for patients with congestive diseases. Hello? Anybody on the call, can you please give us the definition of low sodium content antacids? Hello? Please, can you hear me?
Yes, please, sir. Can you hear you?
Okay. So these are important. You don't just give any antacids to any patient. Some patients can't tolerate excessive sodium. Okay, so when we say low sodium content antacid, if it's a tablet, for example, then one tablet must not contain more than 1 millimole of sodium. One tablet. So let's say aluminum trisilicate tablet. We classify that tablet as low sodium content. It means that one tablet should not contain more than 1 millimole. And if it is a liquid preparation, then 10 mils of that liquid preparation should not contain more than 1 millimole of sodium. And this will be perfect for patients having problems with congestions, heart failure, kidney diseases, and what have you. The main disadvantage is the type of metal that you have in the antacid salt. Even with that, we can use strategies like combining two agents with opposing responses to try and take advantage of the pharmacokinetic interactions. One will cause this, one will cause that. We cancel out, or the pharmacodynamic interactions. Diarrhea will be cancelled by constipation. Aluminium, constipation. Magnesium, diarrhea. In one product, cancelled. Calcium containing, rebound acid secretion. You remember we said the muscarinic pathway is calcium dependent pathway. And therefore, anytime that you have calcium present, that pathway is enhanced. And therefore, giving calcium containing antacids can enhance that pathway and then give us rebound acid secretion. So antacids could be used to manage stress-related ulcers. Apart from antacids, we can also mimic mucus. We can mimic mucus by using sucralfate. So sucralfate is an agent that when it comes into contact with natural agents in the body like albumin and fibrinogen, it becomes very viscous and appear almost just like mucus, forming a barrier protecting the GI lining from direct contact with aggressive agents like HCl, digestive enzymes like pepsin. That helps a lot. So you can use sucralfate to mimic the effect of mucus production. Then other drugs. So we use agents that antagonizes the various pathways of acid secretion, notably the H2 receptor antagonists. We have cimetidine, ranitidine, so the tidines. These are very, very good agents that can be used. What they do is to antagonize the histaminergic subtype 2 that is found on the basolateral membrane, as discussed last week. You block it, then you are minimizing that pathway of acid secretion. Unfortunately, when you block it, the system tries to enhance the other two remaining pathways. And that is what normally brings about resistance or tolerance to this pathway blockade. I repeat, there are three possible pathways through which acid is secreted: histaminergic pathway, muscarinic pathway, and the gastrin pathway. All of them will pass through the proton pump to release acid into the lumen. You can selectively block the histaminergic pathway using agents like cimetidine and the rest. Very good agents. But when you do it, the unfortunate thing is that when you cancel that pathway, the other two pathways are enhanced. And through this mechanism, you will realize that by day 2, when you put a patient on ranitidine and co, you may realize that the response begins to diminish. You are not getting the same response as you started before. Why? Because blocking that one pathway out of the 3, the 2 other pathways are enhanced, making the drug almost useless. So tolerance develops as early as day 2 when you put patients on H2 receptor antagonist. So that is a limitation. That is a limitation of H2 receptor antagonist. It is a limitation. A very good agent, but because of this process, you realize that you begin to have diminished response. We expect the drug to be working. Why are we having diminished response? enhancement of the remaining two pathways, almost negating the single pathway. But they can still be considered. However, locally, we normally use the PPIs. We use the PPIs. Yes, so these are some few adverse effects of the H2 receptor antagonist. Last week, I recommended that you find any pharmacology book and then read on at least these two, H2 receptor antagonist and the PPI. So I found some few in case I understand you are busy. So in case you decided not to do that, you can read through this. I've added some few pharmacology stuff here so that you know, including drug interactions. So they are key inhibitors of the cytochrome P450 enzyme. So if you are giving them together with other drugs that are also metabolized by some of these isoforms cited here, notably the 3A4, 2D6, 2C9, 2C19, most especially, you may have to think twice because they can cause accumulation. They are going to inhibit the enzymes that metabolize them. If the drug is a prodrug and it is activated by any of these, then the drug may not be activated. If it is also metabolized and cleared by some of these enzymes, because of this H2 receptor antagonist, the drug may not be metabolized. Accumulation may occur and toxicity may be experienced. So that is clinically significant. It's very, very important for us to note that the H2 receptor antagonists, especially cimetidine, they are key cytochrome P450 enzyme inhibitors. Another key thing that we should note is that you must begin to adjust doses, especially when the patient is renally compromised. They are excreted there, and with renal impairment, they may increase their concentration in the blood and cause toxic effect. So when you have enough time, kindly go through the pharmacology stuff. Initially, it wasn't there, but I decided to add them, noting that maybe you may be busy and therefore you may not be able to read. I will send you this slide today because we are going to finish. I'll post it on the common page. PPIs, gold standard. PPIs, gold standard. They are known to be superior to the H2 receptor antagonists. Lucky for us, the resistance that we see or the tolerance that we see with H2 receptor antagonists do not happen in when you are using PPIs. They are very strong agents. They form covalent bonds with the proton pump. They block it. Unless you form new pumps, you can't release further acids. So they die with the pump. Any drug that reacts through covalent bonding is very stubborn. And therefore, PPI is doing that. Can inhibit proton pumps and make sure that acid can only be released if new ones are produced. Examples include our own omeprazole, esomeprazole, rabiprazole, and the rest. These are key agents that are utilized a lot in our ICUs to prevent stress-related ulcers. Very, very key agent, especially good orally. The patient is at their highest risk of developing stress-induced ulcers. And therefore, during that time, PPIs are used. So as part of the routine ICU medicines, you always see drugs like PPIs or H2 receptor antagonists being employed for what we called prophylaxis against ulcers. Prophylaxis, so JIT prophylaxis. We do GI prophylaxis against us as part of routine ICU care. Very, very important agent in our ICU care. Please read. These are all pharmacology notes that I've added. So you can read on them for MCQ purposes. Look at the individual agent and their effect. Some of the effects are class effects. Others are agent-specific effects. For example, as omeprazole is known to be an inhibitor of some of these enzymes, 3A4, 2C9, 2C19, lansoprazole will rather induce. So look at the differences. They all don't inhibit. Some of them inhibit, some of them induce. For MCQ purposes, examiners can pull this trick on you, tell you that all PPIs are enzyme inhibitors, true or false. And they'll say among the following, which one is an enzyme inducer? And you see lansoprazole, omeprazole, esomeprazole, rabiprazole. Then straight away you know that lansoprazole has the capacity to induce. Now, there is this evidence that we all know that PPIs can inhibit. And therefore, when you take them with prodrugs, especially clopidogrel, if you are doing secondary prevention for patients who are at risk of atherosclerotic cardiovascular conditions, you can employ the use of clopidogrel, which is a prodrug that must be activated by the cytochrome 2C19 subtype. We've always been hearing about the interaction between PPIs and clopidogrel. Failure for activation to occur because PPIs will inhibit. But recently, it has been found that it is there, but clinically, it is not significant. So it is there, but the clinical significance is not that much. And therefore, one may still use it. As for me, the fact is that the inhibition as per recent findings is not clinically significant, even though there is that evidence of that interaction. But the moment you get statistical significance, it doesn't always relate to clinical significance. So in clinical research, apart from the statistics, clinically, the results that we are seeing is also significant before recommendations can be made by the various recommending authorities. It is there. Statistically, it is significant, but clinically, the interaction is not significant. And therefore, it's not an absolute contraindication. One may still use the two concurrently. But as I said, I wouldn't risk. Why would I risk doing something that has the potential to occur? I would choose the safer option by not doing the two concurrently. Any queries? Any queries? Any queries? Class captain, can we continue? Hello, class captain, are you there? Can you please hear me? Please let me know if you can hear me.
Yes, please.
Yes, please, sir.
All right. So this one, in case you want to read further, you want to read on certain guidelines so that you get enough information on peptic ulcer disease, you can go to these sites and read. Go just check on all these papers. You have enough information on peptic ulcer and its management. These are very good sites or good papers that you can go and then read. Now, let's look at when you have ulcer and it begins to bleed. You have ulcer. It's not every ulcer that will bleed, but unfortunately, some people will have ulcers and then it will bleed. They can even bleed to the extent that it becomes so critical, life-threatening, and may even die from it. Let's look at that situation. So now, it is not also every ulcer that bleeds. that is also clinically important that you must pay attention to it. From time to time, you may see some small bleeds. Fine, you give drugs. But if the patient bleeds to the extent that any of these three issues occur, then we are in trouble. For example, you bleed to the extent that you have a decrease in blood pressure of 20 millimeters of mercury within just 24 hours. That is dangerous. So, for example, your systolic BP was around, let's say, 120. Then we realize that you are having GI bleeding. And over or within 24 hours, your systolic BP drops by 20 millimeter of mercury. Why is it dropping? You are losing excessive amount of blood volume. And once your blood volume is compromised, it will affect both peripheral resistance and cardiac output. When these two decreases, automatically, they are directly proportional to mean arterial pressure. And of course, your mean arterial pressure will drop. If your MAP drops, you are in trouble with perfusion, and that can create a lot of multi-organ dysfunction. And therefore, we don't want this to occur. Or if you have a decrease in blood pressure of 10, and then with the response, with the body's own response to the decreasing blood pressure, there is an increased heart rate of 20 beats per minute or more, especially when you stand from a sitting or lying position. That is also significant. It's a sign that indicates that you are bleeding. You are actually bleeding. Or when you bleed, and then we check your hemoglobin and it decreased by 2 grams per deciliter, or you need 2 units of blood within 24 hours to rescue the situation. It means that the bleeding is significant. So when you have any of these situations happening, then you must pay attention to this patient. It's not every bleeding that is bleeding. But when the bleeding results in any of these three, then it means that we are in serious trouble and the patient demands serious attention. Class captain, any issues? Any issues? Please, can you hear me?
Yes, please, sir. We can hear you, sir.
All right. Okay. Again, there are certain scores apart from these three scenarios. There are additional scores that we can also use to assess how significant a person's bleeding ulcer is. And therefore, even if it is important for us to consider aggressive treatment strategies like endoscopic treatment, example, endoscopic electrocoagulation. So we go in there invasively, we push in some endoscopy, then we try to heal the wound and stop bleeding at once. This is very invasive, and therefore it's not easy, it's not comfortable at all. So before you make any decision to go by this uncomfortable strategy, you must be sure that yes, it is indicated, so that you don't waste time, you don't waste resources, or you don't put any patient in any uncomfortable situation. There is this score called the Glasgow-Blatchford score, the Blatchford score. And this can help us stratify or can help us assess if the bleeding is severe, and therefore there is the need to throw in these invasive interactions. So this is how the Blatchford score looks like. Now, it states that if the patient fits the following criteria that we are going to discuss, then the individual is unlikely to require any endoscopic treatment. If the patient fits this criteria, then there is no need for you to do, meaning that the bleeding is there, but it's not serious. So don't waste your time putting the patient into stress by doing the endoscopic therapy, which is also expensive and which will waste much time of health professionals. So what are these parameters? Now, if you check the patient's urea and it is not more than 13, it's not more than 13 for males, or in females, not more than 12, then it means that there is no cause for alarm. How do you relate this to the bleeding severity? How are we relating urea to the seriousness of bleeding ulcers? Can somebody relate? Is there even sense in trying to relate the levels of urea to severity in bleeding? Lana, please, are you around? My lady, Lana. Lana, are you there? Lana, please, are you there? Let me speak to the call and then try and then find some few names. Yes. Josephine, yes. Josephine, my namesake. I'm also Joseph. Josephine, are you there? Josephine, can you hear me? Okay, Kezia, are you there? How do you relate urea, the level of urea to bleeding severity? How does this even connect? Kezia, please, are you there? Please, you need to contribute to make the class. Please contribute. Let me see. Dela.
Hello, sir.
How do you relate it?
So please, in patients with GI bleed, the blood would enter into the GI tract and to be digested. And so the hemoglobin from the red blood cells will be broken down in the gut into amino acids, and these amino acids can be absorbed into the bloodstream. The liver is going to actually convert the nitrogen from these amino acid into urea, and that will result in serum BUN rising.
Okay, so this in part explains the connection. Thank you very much. So this is in part. Another issue is the moment you bleed, you are losing blood, hypoperfusion. So now that you have your plasma urea going high, hypoperfusion against the liver, you are going to have prerenal AKI. You can't also excrete the urea, and therefore high levels of urea can be related to GI bleeding in this manner. In part, your colleague explained, bleeding, you get the amino acids being converted to ammonia, the ammonia converting to urea. If you get urea, it must be excreted by the kidneys. Unfortunately, if the bleeding is that severe, you are going to have hypovolemia, resulting in hypoperfusion. Obviously, you are going to get prerenal AKI. In prerenal AKI, the higher concentration of urea can only go high because it's being produced, but you can't excrete. And therefore, if yours is not that high, it can be related that, for example, in males, if you are not going above 13, then you are not bleeding that much. If you are bleeding that much, it will go high because you'll be producing more, and at the same time, due to hypoperfusion, you can't excrete. In females, 12. So this is how you connect. The next one is straightforward. Once you are bleeding, if it is severe, you are going to have reduced hemoglobin. Remember, one of the possible etiologies of anemia is blood loss through bleeding. So obviously, if the bleeding is that severe, you expect hemoglobin to go down. If hemoglobin is high, for example, in males, if it's still higher than the lower limit of normal, 13, and in females and children too is high, then it means there is no cause for alarm. The patient may be bleeding, but because the hemoglobin is still intact within range, no cause for alarm. Systolic BP, if you are losing blood heavily, hypoperfusion or hypovolemia, you are going to have issues with reduced cardiac output and reduced peripheral resistance. This will reduce your BP. And therefore, if BP is still normal, then it's an indication that, yes, the patient may be bleeding, but no problem. But the moment the BP drops, let's say the systolic BP drops to below 90, then the patient is stepping into shock, hypovolemic shock, below 90, then we are in serious trouble. It depicts heavy bleeding. But with this, higher than 110, there is no cause for alarm. Obviously, if you lose blood and there is hypovolemia, there will be hypoperfusion, counter-regulatory mechanisms. One of them is what? Sympathetic activation. This will increase the person's pulse. This will increase the person's pulse. So when the person's pulse is below 100, it also means that there is no cause for alarm. If the person is really, really bleeding, then there will be hypovolemia, there will be hypotension, and therefore, as part of the responses, you will have the pulse going down. Now that the pulse is still below 100, then there is no cause for alarm. And therefore, the Glasgow-Blatchford score has it that if the patient meets all these criteria, then there is a strong indication that, yes, bleeding may be there, but is not significant enough to warrant invasive strategies like endoscopic electrocoagulation. But if the patient fails this, then that could be an indication. So, for example, if you use the score to assess a patient and the patient score between 0 and 1, there is no cause for alarm. There is no cause for alarm. But the moment the patient scores 6 or more, then it means that there is more than 50% risk for the patient to be having heavy bleeding, and therefore it is possible for all the complications and the negative outcomes that we can suspect from heavy bleeding to occur. With this, then you can activate invasive strategies like endoscopic electrocoagulation. We are doing this scoring system so that you pick on any patient and straight away you are doing endoscopy. You are wasting everybody's time. You are wasting resources. There must be a clear indication for such strategies before you decide to go in. If not, you'll be wasting everybody's time, resources, including cash, and convenience. These strategies are not convenient at all. They are stressful. So this is how you determine whether to go in invasively to arrest the bleeding or not. Now, there are further scores that you can also do to predict mortality rates. So it means you want to predict the outcome. So even before you do the endoscopic therapy, you can also do the Rock-All score. You can also do that. There are several other scores that are there, but these are the UK scores. You can do the Rock-All score to assess the person's chances of dying or surviving, in case maybe you decide not to do the invasive endoscopic regimen or strategies. So before you even do the endoscopic score, you can do the Rock-All score also to know the patient's chances of surviving or dying. So we have the pre-endoscopic Rock-All score, and this gives you the chance to predict the person's chances of surviving or dying. So these are the parameters or the variables that you score, and these are the scores. So you score the person's age is a risk. Aging is always a risk factor. So you can see that as the age advances, then we give you more scores. So less than 60 is 0. 60 to 79, we give you 1 point. But above 80, we are giving you 2 points. Then we look at whether there is shock or not. Of course, if the bleeding is massive, the patient will lose more blood. There will be hypovolemia, and there could be hypovolemic shock, which indicates severe bleeding. So is it there or not? So you can use the parameters, systolic BP. Once it is greater than 100 and even greater than 110, there is no cause for alarm. So you score 0 for the patient. The opposite of this is the pulse. The opposite of this is the pulse. Once the BP reduces, the pulse will go high. So the two works hand in hand. So as long as the pulse doesn't go above 100, again, there is no cause for alarm. We give 0 points to the patient. As things begins to worsen, then we score the patient with shock, 1 point. And then as it gets worse and worse, to the extent that it may even demand inotropic support, we give more scores. Then are there any comorbidities that may further complicate things? If there are no comorbidities, you score 0. As the patient presents with more and more comorbidities, you give the patient more scores. So in all, if the patient's total score is less than 3, then that is what? A very good prognosis. Once the patient overall score, raw cause score, is less than 3, then we are happy. The moment you add up and you get a raw cause score greater than 8, that is red flag. So it means that the patient has a high mortality risk. And therefore, there is a need to throw in your invasive endoscopic strategy. If not, the patient stands a very high chance of dying. So this is what you do before you do your endoscopic strategy. In addition to the Glasgow Blatchford score, you can also do the ROC score, the ROC cause score prior to endoscopic therapy to find out if this patient has a higher chance of dying. And therefore, it's a justification that you go in with your invasive strategy. Then, yes, it was indicated based on the raw score, maybe the Glasgow score. It was indicated and justified that, yes, you must throw in the endoscopic strategy. You have done it. You've done the treatment endoscopically. Afterwards, you must also assess the patient and know whether there is a success or not, and find out if, even after the treatment, there is still the chance for the patient to rebleed. Or to even die from the rebleeding. So you can also do post-endoscopic raw cause score. So that is when you are done. You have done the endoscopic treatment. So additions. So major illness and all those things have been added. So you score the patient based on these variables. Again, age, shock, comorbidities. You want to assess if you are successful or not, so that you know the way forward. So that one too, afterwards, if the patient still have a score of 4 or more, then it means that even after the endoscopic intervention, the patient stands a high chance of rebleeding and dying. So once the patient presents with bleeding ulcers, you can do the Glasgow score to even quickly assess if the patient needs the endoscopic therapy. You can also do the raw cause score. Even if you have decided to do the endoscopic therapy, you can do the pre-endoscopic raw cause score to determine the patient's chances of survival. And for that matter, if the survival rate is poor, it confirms that, or it backs the evidence that you must throw in your endoscopic therapy. You do it, and if it's okay, you start. After the treatment, you must Also assess how successful was the intervention. So you do the post endoscopy ROCO score. Once you do it and the final score comes out as less than 4, we are happy. Less than 4, we are happy. It means that rebleeding, stroke mortality is low. But if you hit 4 or more, then no. It means that even after the intervention, the patient still has a higher chance of dying. And therefore, if you have any other strategy to do, you must employ it. Class captain, any comment, any queries? Are we clear with these scores? The scores are to guide us to take a decision whether we are to go in with our interventions or not. Then after the intervention, how successful are we? The patient's chance of survival, we can also assess with the post-endoscopic ROC score. Any queries?
Hello.
Hello?
Hello.
Hello?
Can you hear me, please?
Yes.
Okay. So for the Glasgow Blackboard score, is there any way to allocate the points? Maybe HB less than 13 will be 1 point or whatever.
Yeah, the chart is there. I forgot to add the chart to it, but I'll look at it and then before I send you the slides, so that you also know how the scores are allocated. Yeah, but it's similar to what I showed you. I'll find that one and then add it. Because you give points as well. Yeah, you give points as well. All right.
Thank you.
You're welcome. Any other queries? All right. So fine. Your patient is bleeding, stands a risk of hypovolemic shock. So how do you resuscitate? So it's not only the endoscopic interventions that can be done. So you need to also resuscitate the patient. The damage has been done, but how do you do it? So you can employ the use of crystalloids. You can employ the use of crystalloids. If the bleeding is massive, such that hemoglobin concentration drops to below 8, 7, 6, 5, then it may warrant hemotransfusion in addition to other strategies that can be used to stop the bleeding. But crystalloids administration, normal saline, Ringer's lactate, and the rest could be given to the patient for resuscitation to stabilize the patient hemodynamically, because heavy bleeding will lead to hypovolemia. It's always not advisable to be using one single crystalloid. For example, if maybe you may have to use 4 liters of crystalloids, then you focus on only normal saline as stated here. Where excessive use of normal saline can also contribute to issues like acidosis, hyperchloremic acidosis. Those who are here who have done emergency pharmacy, your rotation, I'm aware that some of you have done emergency pharmacy. How do you connect normal saline to hyperchloremic acidosis? How can normal saline cause acidosis and hyperchloremia? Normal saline, this harmless agent. We are now saying that excessive administration, maybe during resuscitation, we decided to focus on only normal saline, critically ill patient. Then the patient suffers from hyperchloremic acidosis, and we are implicating the excessive use of normal saline. How? How possible is this? How can normal saline cause acidosis? It's neutral, isotonic, whatever. So let me see. Why am I not getting the names? Scott. Scott, are you there? Quatin, then Teku, I know you guys, at least you guys, I know you've done emergency pharmacy. So kindly help us. How does normal saline cause hyperchloremic acidosis? Quatin, please, are you there? Those who have done emergency pharmacy, where are you? Teku, are you on the call? Where are they? Hello, or anybody, if you can help us, please. How does, because we give normal saline a lot, thinking that normal saline is harmless, but excessive use of normal saline can cause issues like hyperchloremic acidosis. And I want us to try and connect normal saline to that. How does
Yes,
normal saline? Is this
please,
still?
the chlorine will pull hydrogen. The chlorine will pull the chlorine is very electronegative, so it will pull a lot of the hydrogen ions from the intracellular to the extracellular fluid.
Teku, this one it will be difficult for us to understand. So I want you to explain the thing from first principles. How does normal saline relate to hyperchloremic acidosis? Emergency pharmacy. I'm not seeing the names here. Teku, what are your other colleagues? Are they on the call? Or they are part of the in-person team? I can't find.
Well, I don't know whether Sumpa is around, and then Scott, and then I think the other guys they may be in the in-person.
Okay, all right. So then let me try and then take it. All right. So Michael is laughing. Has Michael been to is it emergency pharmacy? Have you done your rotation there? Michael appear.
No, please.
My guys are here, but they are not responding. They are all here. All right. So normal saline is seen to be harmless. We all consider normal saline as a harmless agent. But if you give it excessively, it can cause this problem. Remember already, these patients are critically ill. So the slightest mistake, you are just pushing them off. What happens is that in the body, what is the lower limit of normal of sodium? Sodium. Michael, or the upper limit, or no, you just give me sodium range is what? The reference range, sodium.
135 to 145.
Perfect. And then chloride. Chloride, we are having around, is it 95 or 90 to 110? All right. So let's take the lower limit. The lower limit, sodium is 135. That is representing the positive extracellular cations. Then the predominant extracellular anion, chloride, will be 95. But there must be electrical neutrality. So why is sodium 135, but chloride ions 95? It means there is some deficit elsewhere, yet the body is okay with that. Then there should be something hiding or at the background balancing for chloride. So if you are to subtract, I'm not going to mention anion gap, but that is what I'm trying to explain. If you are to subtract the 95 from 135, then it means the chloride ions or the negative ions do have a deficit of 40. So it means that there is some hidden negative ions that add the additional 40 to what chloride ions is giving us so that it will balance the 135 of sodium. Principally, the anion that will do this is bicarbonate. So let's now forget about all other anions and whatever and focus on bicarbonate. Principally, it is the one that buffers the system. So as you see on the electrolyte panel, you see sodium 135, chloride is 95. There is a deficit going against the negative ions of 40. So at the background, bicarbonate will be contributing that additional 40 to balance the 135. So that is how the system is. And your body is just, you say somebody needs volume. The blood volume of the person has dropped. So you want to what? Increase the blood volume, and you are going to use a certain crystalloid called normal saline. Tieku again. How much sodium and how much chloride do we have per 1,000 mils of normal saline? So I'm talking about the sodium content of normal saline per 1,000 mils and chloride content of normal saline per 1,000 mils. Tieku. I'm on Tieku because I know he has done it. That's why I'm hitting on him.
Please, I think it's 154 millimole of sodium.
Of sodium per 1,000 mils. Is that what you are saying?
Yes, please.
How about chloride? Chloride too is same. So 1,000 mils of normal saline.
1:1.
Yes. Will give us 154 each millimole each of sodium and chloride. So you see, in the body, we have 95 competing with 135 with some other negative electrolytes like bicarbonate, backing chloride. But you are going to introduce, so in the body, sodium doesn't relate to chloride ions in 1:1 situation. Sodium is 135. Chloride is 95 with some additional backers. But in normal saline, you are going to introduce both sodium and chloride into the body in 1:1 situation. So let's say if you give the person 1,000 mils, it means you have given 154 millimoles of sodium and 154 millimoles of chloride ions. Meaning that you are going to give the patient more chloride ions than the patient needs. Because in the system, it is not 1:1. It is rather 135 sodium is to 95 chloride. But you are now going to introduce 154 each. So there's going to be what? Excessive amount of chloride ions in the body. This will result in hyperchloremia. The problem I stated was hyperchloremic acidosis. So now, because you are going to introduce sodium and chloride into the body in a 1:1 ratio, it means basically you are going to create excessive chloride ion levels. And therefore, that will give us the hyperchloremia. Now, how would the acidosis come in? Remember, the backing vocalist who has been supporting chloride ions in the body principally has been bicarbonate. So now that we have introduced more chloride ions, making the negative ions higher than the positive ions now, we need to re-establish electrical neutrality. We need to re-establish electrical neutrality. So it means that we must lose some of the negative ions. So what happens is that the backing vocalist, which is negatively charged bicarbonate, is going to be lost. So that one will be lost in an attempt to adjust to attain electrical neutrality. So as you lose bicarbonate, you are unfortunately not going to use hydrogen ions. It is only bicarbonate. You are just losing it to adjust for what you have created by introducing 1:1 ratio chloride versus sodium. So in losing bicarbonate without losing hydrogen, that will give rise to the acidosis. And therefore, if you combine the two situations, you get your hyperchloremic acidosis. You are losing your natural acid buffer just to re-establish electrical neutrality in bicarbonate. You lose bicarbonate without losing hydrogen ions. That will create acidosis. And by introducing chloride and sodium into the body in 1:1 ratio, you cause hyperchloremia, and therefore normal saline excessively when introduced into the body can cause hyperchloremic acidosis. So be careful. Don't think that normal saline is clear, like it can't cause any problem. It's just normal saline. No, it can create problems. And in critically ill patients, if you misbehave by interfering with the electrolyte balance and pH balance, you can cause a lot of problems. Class captain, are we okay?
Sir, please, sorry, please, can you take us through again?
So we are looking at normal saline, possibly causing hyperchloremic acidosis. We regard normal saline as harmless, just as we always give funds to paracetamol, except liver issues. We think that, oh, it's harmless. Normal saline too is seen as harmless. But if you give it excessively, that's why normally you see clinicians mixing. They won't only write normal saline if, let's say, they want to give 4 liters of a crystalloid. They will give, let's say, 2 liters in normal saline and then 2 liters in Ringer's lactate. At times, they can even blend the whole thing with 5% dextrose. If the patient's glycemic levels are not high, then they can even add 5% dextrose. This is to avoid causing hyperchloremic acidosis. Naturally, in the body, the levels of sodium, the lower limit is 135. Lower limit of chloride ions, 95. These are the two most predominant extracellular electrolytes, sodium representing cations, chloride representing anions. But the body must maintain electrical neutrality. So why is it that the positive in sodium is having like plus 40? Because if you subtract 95 from 135, there is a deficit of what? 40 for chloride to make up before we get the balance, the electrical neutrality. We are not seeing this, but the body is okay. It means that at the background, there are some negative electrolytes that are making up for the difference. Hence, there is no problem in the body. The principal negative electrolyte that will do this is bicarbonate. So principally, it is the bicarbonate that will make sure that the deficit of 40 is covered. So that is how the body is. Chloride always lower than sodium by a difference of 40. Bicarbonate adding up the negative ions to balance, to maintain electrical neutrality. Now, you are going to introduce your normal saline. Let's say 1,000 mils. Let's use that one as an example. But in normal saline, you are not sending these two electrolytes in a ratio as it is in the body. Normal saline 1,000 mils will give you 154 sodium, 154 millimoles of chloride. So you are going to introduce 1:1 ratio, that is sodium versus chlorine, into the system that doesn't have 1:1 ratio. So the moment you introduce, it means that you have added more chloride ions than the body expects you to bring compared to the sodium. And therefore, the negative ions are now going to be higher. because you have given more chloride. Though you are introducing it in 1:1 ratio. In the body, it is not like that. So you are going to give what or cause excess levels of chloride, and that will be hyperchloremia. Hyperchloremia. So the balance will tilt towards the negative electrolyte. So electrical imbalance has occurred, more negative ions now. So your body must what? Solve it, else there will be chaos. What happens? The principal backing vocalist in bicarbonate must help do this adjustment so that we don't get more negative electrolyte than positives. So you begin to lose bicarbonate. So bicarbonate moves out with some negative charges, trying to re-establish electrical neutrality again. And as you lose bicarbonate, remember, hydrogen doesn't have any role to play here. So hydrogen doesn't come in. You are only losing bicarbonate. And if you lose bicarbonate without losing hydrogen to balance, that is acidosis you are creating. And therefore, introducing the drug, giving excessive chloride in 1:1 ratio will cause hyperchloremia. And the body's attempt to balance this by losing bicarbonate will also cause acidosis. Combining the two confirms the indication or the statement that normal saline given in excess doses can cause hyperchloremic acidosis. I hope it's better than the first one. Is it better now?
Yes, please, sir. Very, very, very.
All right. So note that. So if you're on the ward and you realize that one patient needs some IV fluids and you are solely pushing normal saline, be careful. This is a possibility, especially where you don't have bedside ABG analyzer to analyze the patient maybe every hour or every 2 hours. You may cause that one. So that will be an iatrogenic cause. And the patient can even lose his or her life from this. Not necessarily congestions and those things, overhydration, but the imbalance of electrolyte and pH can still kill the patient. All right. So as I said, if the bleeding is so massive and the HB falls below 8, then hemotransfusion may be needed as part of the resuscitation. So you do your grouping and cross-matching, and then you find compactable blood. Always remember the possible complications of hemotransfusion, as discussed yesterday. The possibility of excessive iron, that is iron overload, bloodborne infections, several other things that can happen. So patients can get reactions. Serious case scenarios, you can get TRALI, transfusion-associated lung injury, from the excessive inflammatory response mounted by the donor, by the recipient against the donor blood. All right. Now, how do we pharmacologically manage bleeding ulcers? Bleeding ulcers. So now, if somebody is bleeding from the GIT, normally, why don't you go and then use this antifibrinolytics, tranexamic acid, aminocaproic acid? Why don't you give vitamin K? So coagulant. So you give coagulant. Why not coagulant and antifibrinolytics just to stop the bleed? You will never see any guidelines recommending those agents. Even if you use, it may be your own strategy that you are using it. But almost all the guidelines are recommending PPIs. So how does PPIs help in stopping bleeding ulcers? We are not talking about just healing the ulcer. Here, there is bleeding, and we are again using PPIs to stop the bleeding. Subsequently, the PPIs will also help heal the wound. But here, we are talking about active peptic ulcer. That is peptic ulcer that is bleeding, and the drug that we are using is a PPI. Theoretically, it is known, and this translates into practice, that whenever there is any bleeding ulcers in the GIT, like the stomach or the duodenum, and you are able to raise the gastric pH to greater than 6, this helps to stabilize clots that are formed on the surface of those wounds. I repeat, pH greater than 8 is able to help stabilize clots formed on the surface of wounds. And as long as the clot is stable on the wound, there is no way that wound will bleed. PPI is being very strong agent that minimizes acid secretion, can therefore be employed. And once you give them aggressively, they can increase the pH to 6 and give us this stability and therefore stop bleeding ulcers. That is why normally you see at the ICU or at the emergency department, when somebody comes with bleeding ulcers, once they are seen either through vomiting blood or melena or whatever, they normally give them PPI, high dose. Either they do 40 milligram BD or they do omeprazole 80 milligram over 30 minutes. That's a bolus. Then they continue with 8 milligram per hour over 72 hours. Thereafter, if the patient can tolerate oral medication, then they switch to 40 milligram daily for the next 4 weeks. This aggressive PPI administration is to help push the pH to a greater than 6. And once we do that, it is able to stabilize the clot on top of the wound. Unfortunately, this does not reduce mortalities. It can help stop the bleeding, but overall, it doesn't give benefits. It doesn't give mortality benefits. It doesn't also improve the patient's chances of going into surgery as a choice of repair or a way of stopping the bleed. And it doesn't also affect rebleeding rates. That's disappointing. Because we would be happy if this strategy would contribute to survival, would help prevent us going for surgery to rescue the situation, and also will help prevent rebleeding, but it doesn't. However, it can reduce the size of the wound. It can reduce the size of the wound and can help minimize the chance of endoscopy therapy. So with these two benefits, we can get at least reducing the size of the wound and the possibility of doing endoscopic therapy it gives. Remember, as for the bleeding, it will stop. But if it stops, that is not the mere stopping of the bleeding is not what we are after. Outcome measures that are very important are key ones like survival and the need for surgery and the need for, as in prevention of bleeding. However, we are not getting all this. But in a small way, we are getting some benefits. The chances of the patient needing endoscopic therapy to stop the bleeding, this PPI therapy will help us. Of course, it will also help us to reduce the size. Now, guidelines currently doesn't recommend the use of H2 receptor antagonist or somatostatin antagonist for this treatment. Current guidelines doesn't support. So it means the PPIs are the gold standard if you want to do pharmacotherapy. However, in practice, some clinicians will do this and support with antifibrinolytic therapies like adding tranexamic acid to the regimen. But this PPI is what guidelines recommend. Any queries, any contributions, any additions? If not, then that will be the end of our peptic ulcer discussions. Next week, same time, we will come back here
Hello,
and
sir.
tackle. Yeah, hello.
Please, can you come again with the tranexamic acid?
Yeah, so I'm saying that guidelines recommend PPIs, but in clinical practice, some clinicians, apart from using these high dose PPIs to arrest bleeding ulcers, may also add. So in addition, they don't prescribe the antifibrinolytics to replace the PPIs, but they do them as add-on therapies just to help arrest the bleed. So you may see PPIs in addition to antifibrinolytics like tranexamic acid in trying to stop bleeding. However, using H2 receptor antagonist or any somatostatin analog like octreotide is not recommended. You may use this one in variceal bleeding, somatostatin analog in variceal bleeding, that is in liver patients, those suffering from portal hypertension, induced variceal bleeding. But in GIT ulcer bleeding, somatostatin analogs are not recommended. They will rather cause splanchnic vasoconstriction, which is cited or which is implicated as one of the possible cause of our ulcers. So if you are coming in to help and you come with one of our problems, then you are not needed. That is why somatostatin analogs are not recommended in bleeding peptic ulcers. However, they are indicated in other GI bleedings like esophageal varices, variceal bleeding, but not here. Why? Because somatostatin analogs will cause vasoconstriction to the splanchnic blood vessels, which has been cited when we're looking at some of the possible cause of stress-induced ulcers. So we don't want our patient to suffer. If you are coming in to help stop the bleed, don't bring another problem. Just come in and then help. So they are not recommended in peptic ulcer bleedings. H2 receptor antagonists are not strong enough to raise the pH to this level of greater than 6, and they are also not recommended. It is rather the PPIs that are superior, very strong, and therefore can raise the pH to that level, stabilize the clot, and prevent the dislodgement of the clot, exposing the wound and causing bleeding. They help. In practice, in addition to PPIs, some clinicians will add antifibrinolytics like tranexamic acid to augment the effects of the PPIs, trying to stop bleeding. Please, are you okay?
Yes, please.
All right, okay.
Thank you.
Any further questions? Any further questions? If not, this will be the
Yes,
end
I
of.
have a question.
All right.
Since when you were talking about the hyperchloremic acidosis, then you talked about how normal saline has a ratio of 1:1 for the sodium and the chlorine, but the body is not like that, so that's why it doesn't work out. I didn't get what you said about the bicarbonate and the hydrogen after that.
Okay, so it means that you understand up to the level where introduction of normal saline in 1:1 ratio will cause hyperchloremia. You understand that?
Yes, please.
Okay, yes. So the moment you cause this hyperchloremia, it means you have increased the levels of the negative electrolyte, because the bicarbonate is back there backing the chloride, and you have added chloride in 1:1 ratio. And therefore now, in total, the negative ions will be more than the positive ions. The body will have to try and then come back to electrical neutrality. How? It means that now the negative ions that are higher, you must find a way to clear some of them so that we come down to the level of the positive ions. And it is the backing vocalist that is the hidden bicarbonate that contribute to the bicarbonate is the natural acid buffer. Your bicarbonate stores is your natural acid buffer. That is why if you want to diagnose metabolic acidosis, we use bicarbonate levels as a marker. The moment you want to find out if somebody is having metabolic acidosis, you check out the levels of bicarbonate. If it is reduced, it means that the person has been using his or her bicarbonate to neutralize the acid. So now, we are going to lose some of the bicarbonates to ensure that we achieve electrical neutrality. So by losing bicarbonate, remember, hydrogen hasn't been mentioned. So it's not as if you are going to lose hydrogen together with bicarbonate. So you lose bicarbonate alone. And as you lose bicarbonate, it is your natural base buffer that you are losing. And you are also going to suffer from acidosis. So the introduction will cause hyperchloremia, and the body's attempt to correct the electrical imbalance will be to lose negatively charged bicarbonate ions, and this will cause acidosis. Hence, you put the two together, hyperchloremic acidosis. So the normal saline that you see as being harmless, please, it is not that harmless, especially in critical care, where the chances of the patient dying is very high. And this is very serious. So don't put your patient solely on normal saline. If you are to give, or the patient demands high volumes of crystalloids for resuscitation, make sure that you mix. Don't use only normal saline. You can mix normal saline with Ringer's lactate or 5% dextrose. In the case of 5% dextrose, make sure that the person is not having hyperglycemia, or you'll be introducing some levels of glucose in 5% dextrose. Please, are you okay?
Yes, please. I understand. Thank you very much.
All right. Any further questions? If not, next week on Sunday, we will tackle gastroesophageal reflux disease. Hopefully, we can use one meeting for that. The following week, then we do nausea and vomiting, another one meeting for that. So gradually, we are making headways. Small, we will get there. Class captain, any announcement? Any announcement? Bright, are you on the call, please? Okay, so do we have any issue that we want to share? If not, that will be the end of our discussions. I will send the slides on that page, the online page, so that you can have it and then read it when you have any free time. Okay, so on that note, I would like to thank you very much for your audience. Catch you same time next week. If you have any issue, I believe you all have my contacts or Dr. Ishak's contacts. Do not hesitate to contact us. You are always welcome. Just call or text, and we will respond to your calls or text messages. Thank you very much. Have a nice day.